My name is Craig Mahoney. I work at the Iowa Orthopedic Center. Obviously, I've been a practitioner here and partner for 20 years. I do hip and knee replacement surgery and have been involved in non-operative care for arthritis in the knee for quite some time as well. What I want to do today is briefly discuss some solutions for arthritis of the knee, and specifically focus on some newer technologies. I believe there is a way to ask questions, and our marketing and technology team are following along, so they will help us with that. Knee arthritis is incredibly common in the United States. There was a study done in 2012 looking at the number of adults with arthritis, and it was estimated at that point that 50 million people had arthritis. The average age of a citizen of the United States was creeping up at that point. It's become a bit more flat, but nonetheless, there are a significant number of people in the United States that deal with arthritis of their knee. Symptomatic knee arthritis, which means arthritis that requires treatment or changes in activity, has been estimated to be literally half of the population at age 75. There are other studies that have looked at radiographic arthritis. So can I see arthritis on x-rays? And I believe that 50% of patients at age 65 will have radiographic changes consistent with arthritis. So I think what we need to assume and what we need to deal with is the fact that there are many people in the United States that we see day to day who have arthritis in their knees. Those things affect them personally, but also professionally. The working population with arthritis is more predisposed to injuries. So that's definitely something to consider as we attack this process. There are many treatments that don't involve surgery. I do knee replacement surgery. In a normal year, I'll do approximately 200 knee replacements. But many patients come to my clinic wanting things that don't require surgery. I have some arthritis in my body as well, and I would like to put off any type of surgery as long as possible, so I understand that sentiment. There are anti-inflammatory medications and pain relievers that we can take. Some of those are over-the-counter. Some are topical and some are prescription strength. Over-the-counter preparations include things like ibuprofen or Aleve. Many of us are familiar with those. Topical analgesics, which can be purchased over the counter, include Voltaren gel. It's easily accessible. Again, you don't need a prescription. And there are some studies that show that this can be an effective way to treat arthritis. Prescription strength anti-inflammatories, things like Celebrex, Meloxicam, Naprosyn have also been shown in multiple studies to help people treat their pain and improve their mobility in the presence of arthritis. Many patients who have arthritis become less active, and that's an obvious outcome. And I think what's interesting is there are multiple studies which show that low impact exercise and physical therapy can actually be seen as treatments for arthritis. People become less active. My knee hurts. I don't exercise. Theoretically, I gain weight. My muscles get weak. Those things actually contribute to the pain of arthritis. So to try and break that cycle, it's common for us to request and order physical therapy or talk to patients about ways that they can exercise that helps them get in the way of inactivity causing pain. Many of us deal with weight issues as we get older. Our metabolism slows, our activity level goes down, and our appetite can tend to vary, but sometimes even if we eat the same amount of food, because we're burning less calories, we end up gaining weight. Weight loss is a known treatment for arthritis of the knee. There's a very high correlation between weight gain and knee symptoms. And so it goes that if I was able to lose weight in a situation where I'm heavy, that can be seen as a treatment. And as I said, has been proven in multiple studies. And corticosteroid injections are the local delivery of anti-inflammatory medication to the knee. So where we can take pills, anti-inflammatory pills, those pills are obviously metabolized in our body, absorbed into our stomach and small intestine, but they affect every part of our body, and there are some side effects. One way to limit the side effect profile of anti-inflammatory medication is to deliver the medication locally in the form of an injection. So our practice uses a significant number of corticosteroid injections. The healthy knee joint is one where there is a thick layer of articular cartilage. So I'm going to use my cursor here. So what you see here is articular cartilage in this part of the screen. And what you're seeing on this mock-up of someone's knee is this light blue layer. So typically what I tell people is that think of your knee or that your joint is an orange. The orange peel is the light blue layer. It's a normal process for us to have that layer break down. So the older we get, typically the more thin the articular cartilage gets. Now, articular cartilage is living tissue, and so there's ways to keep it healthy, and we could refer back to the previous slide. But in situations where we have abnormal wear, this thickened layer becomes more thin, and as it gets thin, more stress is driven across that cartilage layer into the knee. Knee is living tissue, and it actually has nerves in it. So that stress that crosses the knee joint can be painful. There's also friction involved in knees that wear down. So there's inflammation that's associated with that. The synovial fluid is the fluid layer that coats this. And interestingly, the thickness or the lubricating qualities of the synovial fluid do change as we get older as well. And so what we want to do is maintain a normal cartilage layer. That means nourishing the cartilage cells normally. And there are ways we think we can do that. Certainly healthy diet and, low impact exercise can help with that. But also, decreasing excess stresses in this situation. An abnormal situation is one where there's inflammation. So you see in the far left slide, this layer of reddened tissue is inflamed synovial fluid. And then you see the light blue layer from before, which seems thinned. And that's indicated in this slide with irregular kind of borders of this articular cartilage layer and focal deficits. And then this area here, which may or may not project well on your computer screen, shows a number of different materials that basically indicate inflammation in this region. There can be pro-inflammatory cytokines. There can be inflammatory cells themselves, sometimes white blood cells, and things like that, which can contribute to the breakdown of the articular cartilage. This decreased lubrication and decreased shock absorption, which occurs through the thinned layer of articular cartilage, causes pain. So the x-ray here on the right shows a healthy knee joint. You can see a nice space between the two bones, very regular kind of smooth borders, and really no big bone spurs. And this view to the right, unfortunately, we've lost our joint space. There are bone spurs which have formed in response to that. And you can see that the bone here in the medial side of the knee is actually whitish, and that whitish layer is the bone's response to the pressure of that increased stress. It makes itself harder. There's been a number of advertisements in local newspapers here in Des Moines over the last 2 to 3 years talking about a concept called viscosupplementation. And the purpose of that is to try and create a more normal synovial fluid layer in a knee that has arthritis. If we can replenish the thickness of that fluid, then we think, and there are some studies which support the concept that this helps people feel better. Hyaluronic acid is a normal part of this joint fluid. So in this space, you would expect there to be water, which is the lubricating part, but also hyaluronic acid, which you could think of as the slippery part. And so we want more slippery parts and less water parts as we get older. And theoretically, one of the ways we can do that is through viscosupplementation. This material has been around for a long time, as long as I've been in practice. And again, the companies that make this material would have you believe and support with some studies that show that the protective layer around the cartilage is improved with this viscosupplementation, and that the fluid, the thicker fluid, lubricates better. As I said, there are some studies that support that. There are some studies which show that maybe the case for hyaluronic acid is not as strong as the companies would have you believe. I guess in our practice here at Iowa Orthopedic Center, so many of our patients want to and come in asking for non-operative care, that I think, we supply this. We do a good job of asking for permission from insurance carriers, and whether they're private or governmental, and try and facilitate that process as much as possible. Again, there's no guarantees with this, but there are a significant number of people that we've treated that have seen true benefits with viscosupplement. There may be some products that people on this webinar recognize, Gel 1, Synvisc, Monovisc. Some of this is synthetically created. Some of it comes from rooster combs. Bottom line is, it is something that we offer our patients and have had some success with it. There are a number of studies, again, that I pointed to, and we could talk about all the studies for the next 20 or 30 minutes. I think the take home from this, based on my reading of the literature and my practice, is that there may be some benefit. And that, depending on the study, whether it's Monovisc, Synvisc, Gel 1, the companies have some support for their products based on randomized trials that they've done in patients with arthritis. It's not a perfect solution, but it's another way that physicians such as myself can treat patients who really would prefer non-operative care as opposed to considering knee replacement surgery. Another thing I wanted to talk about today is platelet-rich plasma. So we talked about steroid injections, we talked about viscosupplement. Platelet-rich plasma is actually something derived from the patient's own body. The platelets, we recognize, many of us recognize, it's a material or cells in our body that are used to clot. So when I cut myself, platelets are used in combination with other processes to create a blood clot, ultimately a scab that allows us to heal. And the platelets themselves have proteins and growth factors that are either contained within the platelets themselves, or are carried with the platelets if we were to take them out of the body. And so we know that some of these growth factors have anti-inflammatory properties. This is appealing to many people because we want a biologic solution. That's the title of this talk, is a biologic solution for arthritis. And so this process would occur in our office. You need to be interviewed by a physician like myself, a physician's assistant, and discuss and theoretically request this. Unfortunately, many insurance plans and Medicare are not currently covering this, but it's not horribly costly relative to, what we're paying for other things in our lives today. So you come into our office after saying you want to pursue this and actually have a blood draw. And then we take the patient's blood and put it in a machine called a centrifuge. And what that does is spins at a very high revolution per minute. And we are able to separate the platelets from other cells like red blood cells, white blood cells, and things in the blood itself. Once we separate that out, we can take the platelets and inject them back into the affected area, in this specific setting, a knee. And that process has been shown in a number of studies to actually improve patients' pain, allow them to do more in many studies. And I think, ultimately, create a solution for patients that isn't a steroid, that isn't a synthetic viscosupplement. So studies, again, we could talk for another 20, 30 minutes about our platelets, and platelet-rich plasma superior to placebo, certainly, or is it, how does it compare to hyaluronic acid? So these are 3 studies that were pulled out of the literature in 2016. And all of these studies would support using platelets in this setting. So this specific PRP for degenerative cartilage disease, a review of the literature. So this was a nice summary in the Journal of Cartilage. This knee journal showed improved short-term outcomes in patients who receive PRP injections, and then platelet-rich plasma injections provided a safe and efficacious treatment for patients with knee arthritis, an FDA-sanctioned randomized double-blind placebo-controlled clinical trial. So American Journal of Sports Medicine is a well-read and recognized journal within the orthopedic literature. And so I think there's certainly some evidence and some power for this. A couple of other studies which have come out more recently included this study that looked at PRP, platelet-rich plasma, in arthritis, looking at the correct dose, so the amount that we would inject, and try and come up with an estimate as to how long it would last. And so this specific study did a comparison between PRP and hyaluronic acid and went out to 1 year. And what's interesting is, we use the hyaluronic acid, as I stated previously, but the PRP in this study actually had a longer effect than the hyaluronic acid out to 1 year. So a more durable result in this specific setting. The authors did want to note, though, that the number of platelets in the actual injectable material that we put back in the knee do play a role in the chondroprotective effects. What that means is saving the cartilage in patients with moderate arthritis of the knee. So knowing the number of platelets, the correct number, is important, and that's all really been worked out quite well in the process that we use to try and harvest the platelets. Another study that was released last year in the American Journal of Sports Medicine, again, was platelet-rich plasma versus hyaluronic acid, a systemic review and meta-analysis. So meta-analysis refers to someone of scientific expertise taking a number of studies, combining them, and trying to draw conclusions based on those studies, and trying to draw comparisons based on similar metrics. So a total of 18 studies were reviewed in this specific paper. And one of the summary statements of this group was that patients undergoing treatment for arthritis with PRP can be expected to experience improved clinical outcomes when compared to hyaluronic acid. So again, even though we're using the hyaluronic acid and many insurance plans will cover it, it seems like platelet-rich plasma may be more durable, and the peak effect may be better than hyaluronic acid. So quick little talk here, but to summarize, again, we are the Iowa Orthopedic Center. We do surgery and offer that to patients who are willing, able, and appropriate to achieve good success with surgery. But many of the patients we take care of don't need or want surgery, and we do a nice job, I believe, and I certainly strive to support patients with treatments that don't involve surgery prior to considering surgery. The standard options, I think many of us are familiar with, again, anti-inflammatory medications. I didn't mention Tylenol before, but that's certainly can be used as well. We are proponents of physical therapy in certain situations. Of course, patients who have weight issues, we would support, advocate for, and help patients achieve weight loss. And we do use corticosteroid injections when appropriate. My personal slant on this is in patients with typically very mild arthritis, I try and be judicious with my corticosteroid injections simply because there are studies which show that multiple corticosteroid injections can actually contribute to the evolution of arthritis. In patients with arthritis, I think the benefits of using corticosteroid injections are obvious because it allows people to get around better. But in some of our younger, more active patients with very early arthritis, I offer the corticosteroid injections judiciously. We did speak about viscosupplement, and the goals there are to improve and restore lubrication in the knee to a more healthy situation and potentially offer protection that more thickened fluid would provide. Again, I think the literature is a little bit inconclusive in the mechanism in this specific situation or the ultimate effect. But I would say that in a situation where someone is contemplating non-operative care and they express interest and have done reading and we've talked about it, I think this is something we can certainly use in our clinic to try and put off surgery as long as possible. I think patients who have knee arthritis who consider platelet-rich plasma can expect less pain. I think the studies bear that out. Can expect improved mobility because their pain is less, therefore they're doing better. And when compared to viscosupplement, I do believe that platelet-rich plasma is a good option. I think there are studies that show that it may be more durable and that it also may give an effect that might be greater than the hyaluronic acid. Again, the downside of PRP at this point is insurance plans typically are not providing for this. At Iowa Orthopedic Center, we have tried to make this a very cost-competitive option for our patients. There are a number of clinics that are more forward about their advertising biologic solutions, and they may have a more aggressive cost structure as it relates to this. However, I think we are very sensitive to people's financial situation and recognize that these biologic solutions, specifically PRP, is costly, but something that patients want. So we try and keep costs competitive. And with that, I think I'll open it up to questions. I appreciate the time and the participation. There are a fair number of people on today, which is impressive. So I appreciate your attention. Are there questions?
Dr. Mahoney, it looks like there's a question in the chat. Randy is asking if you've already had an HA series of injections, how long do you need to wait to do the PRP injections?
Yep. So I don't think there needs to be a large stagger between those two. I think, talking about all the injections that we use, I am not comfortable giving people multiple cortisone injections closer than 3 months apart. And again, my concern there involves the effect of the cortisone on the articular cartilage and whether or not it would accelerate the process of arthritis. We don't believe there's any evidence of that in patients who receive viscosupplement. And we also don't believe that there's any evidence of that occurring in patients who receive platelet-rich plasma. So I would say, my own personal opinion is, and I've actually received myself hyaluronic acid injections, I would want to give it a chance to work because I think the effects of those shots they can be positive, obviously, but it's not immediate. In my hands, I usually tell people wait 4 to 6 weeks before you've decided whether your hyaluronic acid injection has been positive. So I would want to wait for that effect, but that's strictly a bias on my behalf. There's no evidence, and I think there are even some physicians. I couldn't tell you who, but I think in meetings that I've participated in, I think there are some physicians that inject those two things fairly close together. So I don't think there's a specific period of time that has to pass before you do that PRP injection.
All right, it looks like we have a few more questions. My apologies if I butcher the name. Regina asked, what is the average cost of the platelet replacement?
The platelet-rich plasma injections currently are $500 here at Iowa Ortho. Again, we're trying to be sensitive to people's, financial situation, and times are hard. There are obviously there's a inflationary period we're all going through, and so we recognize that there is a cost to our clinic to actually process your blood. So there is some cost associated with doing these injections and buying the material that ultimately allows us to do that. But our current cost is $500 per injection.
All right. And Deborah asked, how long does the benefit of the plasma injection last?
That would vary, but one of the citations I'm going to refer back to showed an improvement at a year. So this was the study in 2021 that looked at dosing and long-term clinical efficacy. And specifically, one of the points the authors made was that there was significant improvement in the platelet-rich plasma group at 1 year. So, again, I would love to guarantee that for all the patients that we help with these. I can't do that, but I do think there's potential for it to help for up to a year. So, that's pretty impressive. I mean, if you start doing math on some of these knees we see, if you could receive a PRP injection once a year, that would be a phenomenal way to take care of a lot of arthritis. So that would certainly be the hope, but again, there's no guarantee.
And then Randy has another question. Is the PRP a series of injections or can it be a one-time injection?
It's a one-time injection. So that whole process can occur in a single day where you come in, we draw your blood, we put it in the centrifuge and receive the dose of platelets back and inject that into the body. So it all happens in one day. Again, it can be repeated based on the result, but it doesn't have to be repeated. The most of the injections I'm referring to now are a single injection. Historically speaking, hyaluronic acid injections occurred anywhere from 3 to 5 injections once a week for either 3 to 5 weeks. Most of the manufacturers of hyaluronic acid preparations now have combined the material to allow the patients to receive it in one injection. So in my hands, unless there's an insurance issue or a specific patient request, all of these shots would occur one at a time.